Richard, you want to push the button to make sure it's recording?
Yes, it's
We're
on.
good to go, Jeff.
Okay, so I'm just going to quickly introduce our speakers today. And to be honest, I didn't schedule this. One of our former FDA safety reviewers did before she recently left the FDA. And a lot of emails and conferences like fly through my Outlook calendar daily. And I briefly glanced at the title of the talk a number of months ago and thought, and this will probably reflect somewhat poorly on me, why do we need another grading criteria system? There are a number of them out there. And I have this SITC guide to managing immunotherapy toxicity in front of me, and it's 237 pages. How much more information can one impart, or do we need? Then a few months ago, I saw that Thilo et al. Was presenting, and my thought process completely changed because I got to meet Thilo about a year ago through Christy Schaefer at Hatteras Ventures, who thoroughly extolled his talents. And in the hour we got to chat, left me with the conclusion that this is a down-to-earth, warm, bright, intelligent scientist. So Thilo is the director of the Immune-Related Adverse Events Program at Project Datasphere, and his two collaborators we will hear from today are both assistant professors at Harvard Medical School. We have Kerry Reynolds, who's a clinical director of the Inpatient Oncology Services at Mass General and director of the Severe Immunotherapy Complication Service. And then Dr. Guidon is director of the Myasthenia Gravis Clinic at Mass General and a director in the Partners Neuromuscular Medicine Fellowship. So I have no doubt that these three are going to enlighten us on why we need to have additional discussions and considerations on these immunotherapy-related toxicities, and I leave it to you guys.
Excellent, and I can start us off. First, I want to say thank you for inviting us today. We were close to Shaylee and worked very closely together, so it's great to be here. And Jeffrey, I hope we prove that there is more discussion to be had, and importantly, a framework for defining immune-related adverse events. We're going to talk today about defining ICI-induced neurotoxicities, so a multidisciplinary and consensus-driven approach towards harmonization of immune-related adverse event reporting. And I just want to say thanks again also for all the work that you guys do on a daily basis. Having a pipeline of drugs is so critical for these difficult to treat diseases, and having them not only be effective, but also as safe as possible is incredible work that you do day in and day out. And we're new to this world, so we really are trying to learn as much as possible. But today we're hopeful to give you a glimpse of our world, and then we're most excited about maybe the discussion at the end to really brainstorm, to think about thoughts and think about future directions. So next slide. We have no conflicts of interest, and this audience needs very little introduction. There was notification that maybe it would go to a bit broad of an audience, so we want to just do a quick background on immune checkpoint inhibitors as well to set the stage, but it will be very brief. So many times a day, as we know, the immune system is really trying to recognize between self and non-self. The green cell shown in the top panel on the left is the antigen presenting cell, and the little blue circle is the antigen presented up to the TCR of the T cell. But this is not just one signal in order to get activation. It really must have an amplification or a co-stimulatory signal as well. And that second signal is shown here with CD80 or CD86 and CD28. And then the T cell can be off to the races. So it can start to proliferate, secrete cytokines, start to migrate. But soon, as we know, in order to have checks on the system, checkpoints begin to emerge, and CTLA-4, shown here, goes to the cell surface in order to outcompete to that pro-stimulatory signal. So the first anti-CTLA-4 was ipilimumab in 2011. What a historic and breakthrough moment that was. And then soon as the T cell traffics to the peripheral tissues, it is not obviously just central tolerance, but it's also peripheral tolerance that is key. And so as it traffics, then soon the tissue can upregulate PD-L1 and L2, so the ligands for PD-1, and also serve as checkpoints or breaks to the system to really control this activation. As we know, there are 3 PD-L1 agents that are FDA approved and 4 PD-1 agents. The next slide really shows that in 2011 was that breakthrough approval. In 2014 is when the PD-1s came onto the market. And then the next picture really just gives you a sense of what you guys have done day in and day out. But going from the last 5 or 6 years, it's impressive to see the number of FDA approvals of immune checkpoint inhibitors in cancer therapy. And as a clinician, and as we are on the front lines, it's really important for us to see the trends. And the light blue boxes, not that you can read them, but are all the monotherapy approvals, whereas the dark blue are starting to be the combination therapy approvals. So whether that's immune checkpoint and immune checkpoint, or immune checkpoint and chemotherapy, or immune checkpoint and targeted therapy, it is clear that over the last several years, there are more of these combination or dark blue boxes. And that becomes really important as we see the patients with adverse events, because which agent do you attribute it to? And also importantly, the red boxes here are around adjuvant approvals, meaning earlier lines in therapy. And as we know, that's now the case for multiple types of malignancy. So we're moving to earlier settings. Next slide. And it's a good news story with immune checkpoint inhibitors in terms of response rates that can be over 50% in a variety of different diseases. And honestly, now the drugs are approved in over 17 types of cancer. And we know there are certain approvals with mismatch repair deficient or tumor mutational burden that are high TMB that are actually across cancer types. So it's no longer just melanoma, just lung. And we're starting to see that obviously with the increasing use here at our own cancer center as well as across the country. And when we break peripheral tolerance, right, or if we break both central and peripheral tolerance, it is probably not surprising then that we do see some inflammatory-like side effects. Most common, dermatological. Then we think about GI toxicity, as well as endocrine toxicity. But this is affecting organ system across the board. So neuro, ocular, pulmonary, cardiac, renal, muscle, bone marrow. And these are the conditions that we're seeing on the regular. Next slide shows how frequent these are in our own practices, in our own experience. And for PD-1s, any toxicity can be over 70% and a bit higher with CTLA-4 combination, but often it is actually quite well tolerated, even if there are grade 1 or grade 2 events. What we focus on really is the severe grade 3 and 4. And with PD-1, that's about 14% of the population. With CTLA-4, about 34% of who we treat. And then as we start to combine agents, the severe grade 3 and 4 toxicity does go up. And I always like to look at, well, how severe was it? How many patients really had to stop treatment? And the numbers are shown here, anywhere from 6 to 30% of our patients. And death is the worst case scenario. Thankfully, it is uncommon in that it's anywhere from 0.6 to 1.2%. But I will tell you, these numbers do not really illustrate what it's like to be at the bedside. So for us, many things changed in 2016 when we started to notice an increasing number of patients that were admitted with severe immunotherapy complications. And we had one inspirational patient that was a 64-year-old gentleman with metastatic melanoma. He was treated with ipi-nivo, so the combination therapy, did really well with cycle 1. But 4 days after cycle 2, unfortunately, he presented with very severe pneumonitis. He recovered from the pneumonitis, but a month later presented with both colitis and neurological toxicity. In that second admission, despite everything we tried, immunosuppressive agent 1, 2, and 3, unfortunately, he passed away because of toxicity. And I remember with his neuro event, unfortunately, it was very hard to be able to diagnose this event because we looked at labs, we looked at CSF, we looked at imaging, we looked at nerve conduction studies, but it was not clear what bucket he fell into. And he was so weak, he could barely lift his head or barely even stand up off the bed. And I remember caring for him, and on rounds just a few days before he passed, he looked at me and he said, "Doc, I know this isn't good, but please, tell me that you will learn from this." And honestly, since that day, you'll see that we have changed our complete infrastructure here. And the next slide shows that we are trying to learn from this and learn from all parties and all stakeholders involved. And so early on, we had an MGH symposium with Project DataSphere. This was back in 2018 to really bring the two groups together, Project DataSphere, as Jeffrey pointed out, Tylo and his group, a really key platform agency that can pull together both the academic world, the FDA, the pharmaceutical companies, the patient advocacy groups all together. That following year, we had a large symposium, and that's where we were able to start to really integrate with both Sean Cozen and Shaylee, but I know both have moved on. But that symposium is where we outlined what are the gaps in this field and how do we start to tackle them. And we've launched several work streams as a group since that time. You're going to hear a lot today about the neurological work stream that we launched first, but just suffice it to say that we are doing multiple other areas as well. We are starting dermatological, as well as pneumonitis, endocrine, and ophthalmological as well. Next slide. And for reporting of immune-related adverse events, we really felt like the main symposium outlined how are these reported, both in clinical trials and in real-world data. And we thought with the framework that you're seeing here, can we harmonize whatever definitions we come up with? In addition, can we make them usable by a variety of different providers? Can we make it generalizable, and then can we make it transportable? We'll get into this in more detail in the coming slides. But those key 4 aspects are what we hope for. Because if we looked at the state of reporting, which is what we really delved into in some of those initial symposiums, and even if we take at our own site multitude of different immune checkpoint inhibitor therapy trials, and we look at the case report forms, it is so clear that there are elements that are always present and reported. So what's consistently reported? Well, when the date of onset of the actual AE. Is it related or unrelated to ICI? What was the outcome in terms of the study drug? Did someone have to hold it? Was it permanently discontinued? And the severity, just as Jeffrey said, is the CTC-AE, and that has been in existence. It grades 1 to 5. It was actually based off chemotherapy, though not immunotherapy. What treatment is given to treat the immune-related adverse event? And there's a lot of free text. Let me give you an example. If you pull up an AE chart for the same condition, say it's a patient with hypothyroidism, that starts as thyroiditis, so often inflammation of the thyroid, which gives a hyperthyroid condition. Then the TSH starts to rise and you develop hypothyroid. There are definitely charts which have all 4 categorized. So, and that is probably related to a lot of the free text situation. And then what we've seen is sometimes reported is, what about resolution, meaning change in severity class? So what was the max grade and then when did it resolve? The time to resolution is intermittently reported, whether patients were hospitalized, needed ICU level care, or have really a significant disability long-term. Other serious concurrent medical events, meaning were there other AEs at the same time and were they immune related? You cannot find one AE chart in any New England Journal ICI approval that really tells us if a patient's actually had multiple toxicities at the same time and which of those toxicities overlap. And then it's intermittently reported whether or not how you diagnose the immune-related adverse event, and is that pathological and definite? The dose and duration of immune-related adverse event treatments and how they connect to cancer outcomes. And we notice multiple choice across the forms, but there's no standardization, obviously, between the different companies. So next slide. So we identified the gaps in current immune-related adverse events as a whole stakeholder group, that the disease definitions are unclear, that the categories can be duplicative, just like I talked to you about thyroid, that the CRF format, the case report form, is not harmonized to collect any of this information in a standard way, and therefore it's very hard to pool information on the back end. In addition, grading criteria we're going to show you is not always applicable to immune-related adverse events, and there really are these key clinical outcomes that are missing that we could learn so much from. And now I'm going to turn it over to Dr. Amanda Guidon, who is a neuromuscular expert that we have worked with for years in immune-related adverse events and part of the severe immunotherapy complication service here at Mass General. So Dr. Guidon, I'll hand it to you.
Thank you so much, Dr. Reynolds. It's a pleasure to be here and talking about this topic today. And so I'm going to talk about neurologic immune-related adverse events as an introduction. And we know that with neurologic immune-related adverse events, they fall into one of 7 categories. The first is those affecting the central nervous system, or CNS, and those include meningitis, encephalitis, CNS vasculitis, or demyelinating disease. And the second category are those that fall and affect the peripheral nervous system. So that includes polyneuropathies or other neuropathies, neuromuscular junction disorders like myasthenia gravis, and myopathy. And so really it can affect anywhere along the whole nervous system, as we see here, all the way from the brain to the spinal cord, to the peripheral nerve, and to the muscle. And these neurologic immune-related adverse events are uncommon, but not ultra rare. So the incidence is quite variable depending on how they are studied and the type of publication, but can range from about 1 to 12% of all patients with immune checkpoint inhibitor therapy treatment. And we think that that's probably underreported, just given the challenges with diagnosis and reporting. The peripheral nervous system IRAEs happen twice as commonly as the central nervous system IRAEs. And among that, the most common is myopathy. And then after that, neuromuscular junction disorders and neuropathies. And the neurologic immune-related adverse events have higher fatality rates than other immune-related adverse events, akin to myocarditis relative to other more common but less serious immune-related adverse events. And so I'd like to talk through a patient who I saw in clinic to highlight some of these issues. And I had the privilege of taking care of her a couple of years ago. She was a 61-year-old woman with metastatic squamous cell lung cancer. And she initially was treated with combination therapy. So as Kerry was saying, we use immune checkpoint inhibitors in combination, sometimes with chemotherapies. And so she received carboplatin, Taxol, and pembrolizumab, followed by pembrolizumab maintenance therapy. And during her initial treatment, she developed some baseline hand and foot numbness and paresthesias, which at that time was not worked up and was attributed to her chemotherapy, as we know is the most likely cause, given that she was on two neurotoxic chemotherapies. And then she had disease progression, and she started a clinical trial. And that clinical trial was of an anti-CD74 antibody in combination with pembrolizumab. And she reported that after her first infusions, her sensory symptoms really worsened abruptly. And then over the 4 months that she was on the trial, she had gradually worsening gait abnormality or ataxia and hand weakness. And she was unable to ambulate. She was in a wheelchair, and she was unable to perform any hand tasks requiring dexterity. So she was unable to button her clothes or use a knife and fork well to cook or to eat. And she was initially seen in Neuro-Oncology and then referred over to Neuromuscular Clinic. And her exam demonstrated muscle weakness proximally in her arms and legs, and also her hand weakness. And she had non-length dependent sensory loss. So that means that her hands were more numb than her feet. She had areflexia. All of her deep tendon reflexes were absent, and she was in a wheelchair. So at that time, our differential diagnosis based on her history and her exam included chemotherapy-related polyneuropathy. We sometimes see a coasting phenomenon, and so there can be worsening even after stopping the neurotoxic chemotherapies. Immune-mediated polyneuropathy, akin to Guillain-Barré syndrome. She could have had a baseline polyneuropathy, potentially plus a polyradiculopathy, so abnormality of the nerve root, possibly even due to metastatic disease or her cancer. And then the last item on the differential was possibly her baseline polyneuropathy plus an immune-related myopathy. And so all of those things were possibilities when we went into additional evaluation. And so these are tables of electrodiagnostic studies. First, on the upper left, we have sensory nerve conduction studies, then we have motor nerve conduction studies. And for those tests, there are stickers that are placed on the patient's hands and feet, and then we stimulate the nerve and look at different conduction parameters. And the third part on the upper right is the needle electromyography portion, where we place small recording needle electrodes into the muscles to understand whether there are any changes consistent with nerve injury or muscle inflammation or necrosis. And we performed those studies for her. And so I'm just going to walk briefly through the data that we obtained. All the boxes that are in yellow are not specific to an immune-related adverse event, but are abnormal. And so she had abnormal sensory responses. They were worse in the legs than in the arms, and that can be consistent with an immune-mediated polyneuropathy, but it's also a pattern that we see in neuropathies related to chemotherapy. So that alone was not diagnostic. The next portion were her motor studies. And here she had very prolonged distal latencies of her motor responses, which correlates with abnormality of the myelin or the coating of the nerve. And that was consistent in multiple nerves, along with something called a prolonged F wave, which is also consistent with demyelination. And that finding is not seen in chemotherapy-related neuropathy. That is much more specific for an immune-mediated polyneuropathy and is the hallmark electrodiagnostic feature. We then moved on to the needle electromyography, which I won't go into the details, but was most consistent with the demyelinating process, which is more like immune-mediated than one with axonal loss, which is what we see in neurotoxic chemotherapies. And so the EMG does not give us a definitive etiology, but based on the physiology, it gives a window into what the possible etiologies could be. And based on the electrodiagnostic studies, we knew that she had a non-length dependent sensory and motor polyneuropathy with demyelinating features. And that was most consistent with an immune-related neuropathy. And so getting back to the differential, it really narrowed it down to look that it helped us know that we were looking at an immune-mediated polyneuropathy and not those other things on the differential. Sometimes in these cases, we'll do a lumbar puncture or a spinal tap, but that was not needed here given the more definitive electrodiagnostic testing. We performed additional serologic neuropathy workup, which did not show another cause for her neuropathy, like a metabolic cause or a nutritional cause or other autoimmune disease. And then we performed spinal imaging, which didn't show any evidence back of abnormality or metastases back at that nerve root area. And so we diagnosed her with an immune-related neuropathy based on the timing and the fact that she reached her nadir, so the worst time of weakness, over 8 to 12 weeks after onset. That is characterized as CIDP or chronic disorder and not the acute form, which is Guillain-Barré. She was admitted to the hospital and withdrew from the trial. She was started on prednisone, which was quickly escalated to IV methylprednisolone. And she was given IVIG and followed by a prednisone taper. In terms of her outcomes, she had a very rapid improvement. So she went from being wheelchair bound to walking on hospital discharge several days later. And her symptoms and exam gradually improved over the next 4 weeks, though she had some worsening as we got down to lower doses of prednisone. However, on her follow-up, she came in and had focal proximal pain and weakness in the left thigh and was diagnosed with new metastatic disease. And so she then went on to have radiation and new targeted therapy. And so how would this case be reported on a case report form or CRF in the clinical trial? Well, it really depends. We've seen many possible names for reporting, and that includes on CRF forms or even in the medical chart with ICD-10 codes. And they generally fall into one of several categories. Sometimes patients are just noted to have a neurologic immune-related adverse event, and that's it. So all of the detail that it's neuropathy and not myopathy, et cetera, is not included. And sometimes the coding or reporting is symptom-based. So there might be a code for or a description of weakness or loss of skin sensation or gait dysfunction or ataxia, but we don't have any indication as to the underlying etiology. Or there can be a general category, like this patient had a neuropathy, but as we talked about, that really doesn't explain exactly what she had or give insight possibly into this disorder. And then neuropathy types. So you might have a more specific diagnosis code like AIDP or Guillain-Barré syndrome, or the chronic form CIDP. And actually, on her initial hospitalization, the code was, I looked back and it was AIDP. So it was Guillain-Barré syndrome. But in fact, even in our institution, there was that confusion between AIDP and CIDP. And then how severe was this immune-related adverse event? And so this is a copy of the chart from the current CTCAE. And you can see that the three options for neuropathy are peripheral motor neuropathy, which isn't really what she had, right? She had a lot of sensory symptoms, but she also had weakness. Peripheral sensory neuropathy, again, this was designed for neurotoxic chemotherapies primarily, and that's the most common phenotype in that etiology, but that doesn't describe her. And then Guillain-Barré syndrome, which we talked about, she didn't really have either. And so there's nothing really that fits in terms of the CTCAE grade here, though we would say she probably has grade 3 or 4. Urgent intervention was indicated, but it wasn't life-threatening at this time. And so this is an uncommon immune-related adverse event, but an increasingly common scenario, especially as the indications for ICI therapy and the combinations are expanding. And it really illustrates the challenges of approaching diagnosis of an immune-related neuropathy in patients who have received or who are receiving neurotoxic chemotherapies. If this was all chemotherapy-related neuropathy, we wouldn't give her Solumedrol, we wouldn't give her IVIG, the treatment would be entirely different. And even the implication for whether she could stay on drug would be totally different. And we've seen a number of similar scenarios given this patient population and some of the concurrent issues. So the diagnosis of immune-related encephalitis, for example, or an inflammation of the brain, which can cause confusion and seizures in patients with prior metastatic disease and seizures is very hard. Same thing for a diagnosis of immune-related myopathy in patients with immune-related myocarditis who present with weakness. And we know that these conditions overlap. And so, Dr. Reynolds will now talk about the infrastructure that we've developed to really care for and study these patients further.
Thank you so much. I think that case illustrates so much of the challenge that we have on the day-to-day. And why we think this is so important is even before some of the most recent approvals, even before some of the most recent adjuvant approvals, it was estimated that we'll treat about 233,000 patients in the US alone with checkpoint inhibitor therapy this year. And so even if we take combination out of it and we say everybody is on some single agent, we know that severe events happen anywhere from 10 to 30%. And so that is estimating that we'll have 23 to 69,000 people with a serious immune-related adverse event. And when we think about neurological toxicity, immune-related adverse events with the incidence of anywhere from 1 to 12%, again, you're seeing the numbers there, but that could be anywhere from 2,300 to 27,000 new patients per year. And this is significant in our practice. And at the Massachusetts General Hospital here in Boston, we were seeing an uptick of these individual patients that were admitted of immune-related adverse events per year. That's shown on the left here. And it was really the 2015 to 2016, and then having a case like I illustrated with my pneumonitis, colitis, and neurological toxicity previously. Those made us really take a step back and think about how are we delivering care. In addition, on the right, the yearly change, a proportion of cancer center admissions being immune-related adverse events was also increasing year over year. And so we took a step back and we completely reorganized the way we think about care of these individual patients. So at our own institution, as of October 3rd, 2017, we developed a group, not just of oncologists, but also of all of the other disciplines we may need to care for the multitude of toxicities that can be seen from immune-related adverse events. So we have now 51 members across 6 departments. So it's not just the Department of Medicine, but it's also dermatology, it's neurology, pathology, and so on, and across 10 different divisions of medicine. This first wheel you see is really, we focus on clinical care. So since that time in October 2017, we have been able to see all of these patients together as our unique hybrid group. We meet every other week to discuss cases as well as to learn what might be new in the literature. And the second wheel and second focus that we have is a clinical registry. And that has been key to learn more about these patients, as well as to correctly phenotype them and think about framework for definitions. And then the last piece is really the translational work. So as part of clinical care, we also ask if patients want to be consented to sample collection so that blood is drawn, as well as tissue if somebody goes for a biopsy, or fluid if someone goes for a lumbar puncture. And to the top right, you see Dr. Chloe Villani. She's the director of our Single Cell Genomics Institute here at Mass General. And her lab is really focused on the gamut of looking at secreted factors and looking at what is in the tissue to think about what might be driving these immune-related adverse events. So there are 15 individuals under her lab. Many of them are actually senior level fellows that span both seeing patients in the clinic and working on the samples in the lab. Next slide. And as we have been together for the last several years, we really feel that disease definitions need to be, one, sensitive enough to include the range of possible clinical syndromes that we're seeing, and then also specific enough to give some sense to exclude other etiologies of things that may be going on to narrow the differential. And so now I'll hand it back to Dr. Guidon, because she will talk about the Neurologic Workstream that was launched, again, out of the center, out of partnership with Project DataSphere and multiple other institutions. So I'll hand it back over.
Great. And so as we were seeing these patients, even around 2018, we started to have the idea that we needed new definitions, and we started to think about how that would look. And then we partnered with Project DataSphere in 2020 to develop a registry, and along with that, the disease definitions. And so I'm going to walk through that process and what the product was next. And so in terms of the disease definition process, initially we drafted disease definitions. Then we invited a multi-specialty panel from around the country to be involved in a very structured Delphi consensus process, which included 2 survey rounds and 2 meetings, and then multiple revisions along the way, which I'll walk through. And the whole process spanned from July until the spring of July 2020 to the spring of 2021. And then the definitions, which I'll present, were published in JITC. And so who were the Delphi panel members? Well, the first was the core group of us. So at the bottom, you'll see wonderful colleagues who were integral to this process. Dr. Leanne Burton, Bart Schwalitz, James Hillis, and of course, Dr. Reynolds. And we and the 4 people there, including myself, are all neurologists with different affinities within neurology. And we met weekly to refine these definitions and really put together a draft to go into the Delphi process. And then we invited colleagues from around the country, all these institutions who are seeing these patients, to be part of the consensus process. So there were 27 participants who were involved, just under half were neurologists. And then the rest were comprised of oncologists, neuro-oncologists, and other immune-related adverse event subspecialists. You can see that there were more junior faculty and then more senior faculty. 50% were, most of the panel was really involved in direct patient care. And then the panel was seeing patients in the inpatient and outpatient setting, and then 50% were doing research. So the point of this is that it was people who've been kind of living day in and day out, with caring for these patients, and aware of some of the nuances and challenges of this group. And so back to the question, why do we need another set of definitions? Well, really the experts in this group, over 80 to 90% thought there were big holes. And so they felt that the current, this was the survey that we sent out at the beginning of the Delphi process, and they felt that the current definitions were not capable of identifying subclinical or mild disease, recognizing the spectrum of presentations, differentiating neurologic immune-related adverse events from alternate etiologies. They felt that the grading criteria were not sufficient. We couldn't classify patients for cohort studies based on the existing criteria. And then the classification for the neurologic phenotypes was really not to the granular level that we would need to make discoveries in the translational sphere. And we could not adjudicate neurologic immune-related adverse events in clinical trials based on the current criteria. And so we drafted the definitions and then went through the Delphi process, and this diagram just illustrates the structure of it. The participants responded on a Qualtrics survey form in a very structured way. Those data were analyzed, and we reformulated the questions and went through serial rounds of voting until consensus was reached. And we used a very rigid, predefined definition of consensus based upon the size of the groups and the heterogeneity. And we also had the opportunity for participants to write in free text comments. And those were so informative. So people really could share their experience and opinions beyond what they could express in the rating. And we incorporated all of those comments, or at least had discussion about them in the process. And so this was the classification system that was agreed upon in the consensus process. And so first, at the top, a patient develops new or worsening neurologic symptoms. At first, you have to evaluate whether the timing is consistent with an immune-related adverse event. If not, work up other causes. If the neuro-IRAE is suspected, then the first division is whether it's a central nervous system problem or a peripheral nervous system problem. And we felt that most of the time, oncologists could be involved in the process up to that point and participate in that distinction. Then the next step is, if it's a central nervous system problem, which of the 4 core syndromes is it? Meningitis, encephalitis, demyelinating syndromes, and vasculitis. If it's peripheral, is it a neuropathy, neuromuscular junction disorder, or myopathy? And then for each syndrome, we had 6 subclassifications to really describe these events. So syndrome subtype, whether it's an exacerbation of pre-existing disease or a new presentation, the severity grade, antibody association, whether it was an overlap syndrome with either another neurologic immune-related adverse event or a non-neurologic immune-related adverse event, and then the level of diagnostic certainty. Sometimes even after workup, we're not quite sure if something is an immune-related adverse event, and we wanted the definitions to be able to reflect that. And so each aspect was rated. These were the general statements. In green is what received consensus. In yellow is borderline, red, no. And the first round, not everything achieved consensus. And then by the end, second round, all the general statements did. The general statements were developed for how do we incorporate timing and tempo? How do we describe overlaps? What do we look for with pre-existing neurologic disorders? How do we incorporate improvement with treatment into these definitions? What about paraneoplastic syndromes? And what about non-specific symptoms like headache or tremor? And how do we incorporate that into the definitions? I'll show the peripheral nervous system criteria again. So for neuropathy, which was the focus of our case, you can see that initially there was disagreement about the diagnostic criteria, but in the second round, that also achieved consensus. We developed severity criteria that were more specific. It was based on the CT-CAE, so you could use one with the other. But for each syndrome, we gave examples of what that severity would look like for that syndrome. And to be able to really understand how to apply the criteria. We also went through consensus to decide what would be needed or required for a clinical trial adjudication for these immune-related adverse events. And for each of the disorders, we developed a table with the name of the event, what the subtypes are, the possible symptoms to be educational for the community, and then what the evaluation might include, and then what would be required for a definite diagnosis, a probable diagnosis, or a possible diagnosis. And this is the example from neuropathy related to our case, but we had the 7 tables for each of the 7 core syndromes. And so looking at our patient, she had a CIDP, so that was her subtype. She had multiple symptoms related to the neuropathy, like paresthesias, numbness, weakness, and imbalance and incoordination. She also had supportive examination findings. In terms of the evaluation, she had all of the testing of the common testing. She also had some of the possible testing. And in terms of the criteria, she met criteria for probable CIDP. And we designed the criteria so that definite usually had some pathologic confirmation or other very, very robust confirmation. And the idea that most people would meet probable, and that probable, was sufficient for treatment. And even we might treat some of the possible, but we really wanted the definites to be absolutely unequivocal. And so in terms of the current reporting, so as we talked about, how would we report currently, her episode for a CRF? We would say, maybe she had a neurologic immune-related adverse event, maybe symptom-based or a general category, and the severity was unclear. But with the revised framework, there is a lot more detail that's able to be described, but it's pretty simple to follow through. So we know that she had an immune-related peripheral nervous system event. We know it was a neuropathy. We talked how it was CIDP. She was in the probable category, grade 3. It was de novo. She had no history of CIDP. She had no relevant antibodies, which is not uncommon, and there were no overlap syndromes. And so how would this look if we were going to think about making this into a CRF? Well, we would still have the general criteria like the timing, which is of course key. And then we would have the major divisions. So is it central nervous system or a peripheral nervous system event? And then one of the 7 key subtypes. And then this reflects the 6 additional descriptive characteristics. So what is the syndrome name, like CIDP? Was it de novo or exacerbation, the maximum severity, antibody association, level of diagnostic certainty, and then the concurrent immune-related adverse events. And then some key outcomes. This obviously is not a complete list, but some of the really important large outcomes, like was the patient hospitalized, what treatments did they get, and then did they have neuro symptoms or disability upon follow-up. And so I'll transfer back over to Dr. Reynolds to talk about applicability and applications.
Yes, so I think at the crux of this is really what is the usability. And if we were able to use a basic framework, for example, this neuroimmune-related adverse event, thinking about what are the minimal data elements that would help us learn from these cases across the board, both in real-world data sets and trials. And really just thinking about symptoms, thinking about how critical it is to know diagnostic certainty, how important it is to know overlap. We have brought up the situation of myasthenia gravis, myositis, and myocarditis, but we're seeing a worse prognosis. We need to know which of these groups overlap together and which kind of start overlapped versus sequential. In addition, when do immune-related adverse events resolve and how long do they last? And is there a need to re-escalate? At this point, there's so little data out there, despite the thousands of patients that have been in trial, about how often we need to re-escalate treatment of an immune-related adverse event or use a second-line immunosuppressive agent if the event was refractory. And then just like Amanda brought up about the hospital, the ICU, and just some of those overall outcomes so that we can prepare for caring for these patients. And why is this important? I think this is the crux of the issue. I hope we have been able in this 50 minutes to date to really try to illustrate, but creating neuroimmune-related adverse events consensus definition is a key step towards thinking about data harmonization and then aggregation of data across trials and academic centers. Even as we put our registry together, if we're pulling cases from other academic centers, it is going to be important to have the central framework. And we really feel by creating consistent and data standardization, we could dramatically improve the quality of immune-related adverse event reporting. And if we can improve the quality and if we can pull cases, because these are relatively rare, especially with the severe events being more towards the 1% of cases. Then we can start to aggregate larger numbers of patients from similar trials and similar data sets to be able to really study the important aspects. Jeffrey and I were just talking right before the session started, but what are the risk factors for immune-related adverse events? What is the time? How can we get ready for the immune-related adverse event onset? And what about the variation in phenotypes? And is it just one organ that's involved or multiple? And what are the clinical manifestations that we're seeing? We can look at then the impact of time to treatment on toxicity outcome. We know, for example, in myocarditis, we actually need to give the therapy quickly with steroids. Within the first 24 hours has wildly different outcomes versus if you wait over 72 hours. And we could look at comparative effectiveness of treatment strategies, because the reality is probably having very large multi-center trials to treat immune-related adverse events is not always going to be feasible. We could also learn a lot from the percentage of refractory cases and knowing how long it takes for cases to resolve. And so our take-home points today are just that obviously immune checkpoint inhibitors have revolutionized the treatment of cancer. This is a good news story. The field is rapidly expanding. That's why we think the time is now. The use of the ICIs in combination, this is the crux as well, because it's increasing and it makes it even more difficult to attribute adverse events. But clear definitions and a usable diagnostic framework would absolutely help. And currently there's this lack of standardization in all the documentation and even in a lot of our publications, limiting our ability to pull data. And lastly, the neuroimmune-related adverse events were created and published, as we talked about. That's why we're here at a journal club. But this is a proof of concept that we can also do it in other immune-related adverse events. And the key then is adaptation. And that's going to take buy-in, and not just from people that see these patients or patients or families themselves, but from all stakeholders. But the patients absolutely deserve it. One of the greatest joys we've had is to work with patient advocates along the way. So they are part of our severe immunotherapy complications clinical and translational program as well. So we are so thankful to them, the patients and families. We're thankful to our neurological colleagues. Obviously, you got to meet Dr. Guidon today, but we have Dr. Burton, Dr. Hillis, and Dr. Schwalis as well at MGH. Project DataSphere, many of our collaborators are on the line, as well as our entire sick service that we work with here at MGH that have been working on this for several years. And now we're open for questions, and we'd really like to, we'll take comments, thoughts, questions, whatever it is, because we'd love to learn more from your end as well.
Yes, hi, this is Maitri Hazarika. I'm an acting associate director for safety in oncology. So I really found it interesting that you talked about the CTCAE, because we are hearing about it with other organ systems also. And it sounds like based on what you presented, maybe you're talking about increasing the grades or even increasing more terms and all. I was just wondering, because the CTCAE 6.0 is underway and will probably come out next year, were you able to provide input into that, and what kind of feedback did you receive from that? Thanks.
That's a great question. So the CTCAE 6.0, we work closely with Dr. Elad Sharon, and he has been very involved, as SITC has been involved in general. So there is some crosstalk. It is not clear how much it will feed or how many of the specifics, but that's exactly why we kind of framed it out in the JITC paper, was because as these are coming into the fold, at least they know that 25 centers felt that some of the modifications in one arena would be helpful, because largely the framework and the structure actually still works. Even though it was for chemotherapy, we really do feel like it works. It just needs to be modified. So we are trying to get the message. We do not sit on that panel directly, though.
Thank you.
Great presentation, Dr. Reynolds and Dr. Guidon. I wanted to just ask you your thoughts about, I know that the neurological toxicities was like a use case scenario for probably expanding to others. but I know from our standpoint, at least, we have realized some challenges in expanding that to, other toxicities. For neuro, I guess the baseline is normal, right? So there's no abnormalities. But then there are, other immune-related toxicities where the baseline, may not be normal. So for example, hepatitis, where there's more confounders that we see, where you can really sort of, make that normal baseline determination to begin with, and then how do you sort of define things, on top of that abnormal baseline. So especially with meds or, whatever it is that's causing those abnormalities at baseline. So have you sort of found that certain immune mediated toxicities may be more challenging to apply this sort of concept for definitions to?
That's a really great question. And I think even I'll talk about both the challenges of maybe other organ systems, but also just on the ground and how we think about managing those patients. And the issue is it's all about the change or the delta, right? And that's kind of what we're watching over time. And then let's take your example of hepatitis, for example. If there were already elevated LFTs, but someone comes in with 3 to 4-fold higher elevated LFTs, we always take a step back and go very systematically over that differential. Is it, unfortunately, that the disease got worse, so you have to image? Is it that they developed a clot because they have progressive disease and it's Budd-Chiari, so you have to really get the Doppler? In addition, we kind of go through all of the recent medications that can also cause hepatitis in addition to the immune checkpoint. And at the end of the day, if it's still unclear, our group really does feel when you get up into the grade 3 and 4 severe toxicity, tissue is the issue. And so many of those patients may need a biopsy if you don't find a cause that you can attribute that change or that delta in the baseline function. Now you get up into the situation where not everything is easy to biopsy. Right. And so, for example, if we even take pneumonitis, we are working on a work stream of pneumonitis because this can be incredibly challenging, especially when you have lung cancer patients who may have had radiation already, who then have both immune checkpoint inhibitor and chemotherapy together. And how does that look? Because infection is on the list as well. And so some of those other organ systems where there is not an easy test or not an easy biopsyable lesion are very challenging. We are still working at it though, because I think the more we develop frameworks for people and the more that we can say lean this way or lean that way in the possible, probable, and definite could be very helpful. So we're not going to stop, but you're exactly right. It is not all the same. And it really has to do with often how easy is it to pathologically determine.
Absolutely. And just to add to that, the neuro isn't always normal, either, particularly as the indications, for ICI have expanded and patients have received the neurotoxic chemotherapies or have brain mets, with prior radiation. So, we hope that the idea of de novo, versus exacerbation could be expanded based on the system, to include some of those nuances.
Yeah. I mean, you're absolutely right. I mean, I was just thinking more in terms of the number of, and maybe that's really not true even, you can have tremors at baseline, you can have so many things at baseline. So yeah. My second question, and I don't know if others on the call have questions, but I wanted to talk about, the CRF that you mentioned and showed about the neurotoxicity. I do think that is a very specialized, neurotoxicity specific CRF. So are you envisioning that, apart from the generic CRF for other adverse events, you would then have these CRFs that, will collect data for these specific immune-related toxicities? Like, what is the concept of this? Is this like a two-step process where you'll do the CRF for all AEs, as part of the protocol, but then you would have these sort of triggered, is sometimes being used for that term, triggered CRF for just that immune AE collection?
I can take the first because you're exactly right. The usability is always tricky if we had these specialized CRFs, say for each adverse event, meaning immune-related adverse event, that does get somewhat unwieldy. But as we navigate this next step, more and more trials are even coming up with that will be thinking about immune-related adverse event treatment. And in those, we may have to get detailed. And I think at the end of the day, we showed what could be a very good gold standard, especially for, say, immune-related adverse event trials and for pulling data. You know, there's so much information on the FDA on the back end of what you have besides the CRF, that if we were really going to start to pull data and analyze cases and look at them in aggregate, this is the information that we need. And then at the end of the day, that minimal required data set, if we could agree or get pharma to agree across companies that just the minimal required data set elements that I kind of mentioned before, I think those are reasonable to start to include. We are definitely trying on multiple different forums. Project Datasphere has been very helpful. They might be able to talk a little bit more about the messaging as well, but we do feel like there are some core elements that are varied between the different trials that have a lot of potential to analyze. And then specifically for either neurological immune-related adverse event or IRAE trials to get more specific when we're talking about the AEs. And then lastly, if we're going to create a national registry and spend money to pull cases together, that we have it according to the same parameters.
And then also just to add, you know, I think we designed these criteria with the non-neurologist in mind. So, you know, we had a lot of non-neurologists on the consensus definition panel, and you know, we wrote the paper so that it was like an educational guide in how you might come to that definition. You know, knowing that some of that granularity might not exist for every patient. But, you know, with symptom lists and neurology colleagues helping at if appropriate, you know, it was designed to be useful and used for the non-neurologist with that supportive guide of the tables and paper. So I think if, you know, if other systems were able to do the same, it would be a lot more usable.
So this is Jeff. Can you, and I'm just going to ramble here, and there's going to be a couple questions in there. But one, so you're preaching to the choir, at least to me, and Abby and Maitri are the safety folks now, and they run the safety team. But there is a guy that used to do that, and he was involved in the harmonization of all the immune-related adverse reactions in the labels. And so the reason you're preaching to the choir is having seen all the various different manifestations of data collection in case report forms and various definitions, and trying to even to just thyroiditis and people calling it resolved because it went from hyperthyroidism to hypothyroidism. I'm like, that's not resolved. So, you know, these are obviously important issues. The neurology algorithm that you have there, I applaud, right? You know, if it's, but remember, there's so many caveats here with how burdensome is this, and I think Abby was getting to that here with all, you know, people don't want to have extensive case report forms and collect all this data, and they're like, why do we have to collect all this data? You know, so the least burdensome it is, and that, you know, not to have so much specialty care would be helpful. And what the other, and then you know, I have lost a battle with CTCAE, but had fought it a decade or so ago, in that, you know, you point out that there are not the appropriate immune-related neurological conditions in CTCAE, and hopefully maybe, you know, they will come. But, you know, MEDRA, I have no doubt that of 17,000 preferred terms that it's in MEDRA somewhere. Now, granted, there isn't the appropriate grading, but, you know, somehow, you know, that's why I like the algorithm, but it's, you know, I would just promote that we use, you know, MEDRA terms, because that's what we're supposed to collect and report, etc. And then the last tirade or last thought was, you know, when that poor patient that died of multiple immune-related, you know, organ toxicities, you know, and I don't do this, right? So I haven't seen a patient in a decade, I bet. But I would have thrown Campath at him at the end or something, right? Alemtuzumab, just, you know, if there was nothing. I mean, what do you guys do? I mean,
so we've learned a lot since 2016. You know, Jeffrey, it's even worse because when he asked us to learn from it, we actually went to clinical autopsy, and there was not.
I think Kerry's frozen for a second. I think
I was going to get an answer and she disappeared.
Now it was
you froze for a second. Do you want to repeat?
No. Anything? Is it back yet or no?
It's back. Yeah.
Okay, so I was just saying that you know, when he asked us to learn from it, we went to clinical autopsy and there was not one S100 positive melanoma cell. So it's completely eradicated from the lung, complete response, really remarkable. Now, if we had to step back, he really died from overwhelming colitis, and we would think about actually escalating quite a bit. So we used infliximab ×2. We're starting to think about vedolizumab as well, an integrin inhibitor. You're not wrong to think about Campath, or even in certain cases of refractory and very serious conditions, we're using abatacept, which is a CTLA-4 agonist, but we're still throwing the kitchen sink. Just like you said, you know, this is how we're starting to treat these patients with severe immune complications. So I guess we're so desperate to have a better understanding of all of the complications that have happened to date in the thousands and thousands of patients, to start to learn from that, because we don't think that we'll be able to get, you know, $15 million 45 center trials easily.
Thanks.
Yeah, I think with that, I don't know if there are other questions from those on the line. You know, we are over time.
Yeah, hi,
Go
Mike
ahead.
here, Norcross. I did have a couple of issues. I think I applaud you two. It's really interesting today and great. But the problem is the combination therapies are going to make it so hard to figure out really what's causing these adverse effects. And I know you mentioned you have a lab that's kind of supporting either single cell analysis or, other immunology or scientific, ways to dissect this. But even, for instance, like the second case, Amanda, I think you brought up, it was anti-CD74, and I was trying to figure out what that was, and on top of anti-PD1, and then you got this neuropathy, and part of it is like, what is each one of those actually contributing to this? So part of what I see here is that you're going to collect these cases, and that's this problem with going with so many combinations is like, I don't know how you're going to figure out really what was it's all in the immune checkpoint inhibitor bucket, but that's becoming so complicated that going back to figure out the mechanism, I think is going to be really difficult. And I don't know whether you're collecting peripheral blood cells from people before you start. I don't think so. But, even in the end, to try to figure out what caused that is going to be complicated. But it sounds like you're going to have a cohort to follow and try to figure out. But anyway, those are some of my thoughts.
Yeah, I have to agree. It speaks to really better diagnostics are needed. And is there an immunoprofile of some sort? Because our CSR and CRP, they're just not effective. There's not a good way to differentiate just yet. You are exactly right that we are getting blood. And then at the time of tissue biopsy, we're also getting tissue. Then we are pairing that with the biobank that exists at the center. So we have about 50% of the cases that have toxicity that we can collect from also have a baseline sample. So we have to track that over time. Is that going to be a certain immunoprofile? Is it going to be a certain TCR clone? Like, what is going to give us the understanding of that they're developing a true immune mediated reaction versus just treating everybody empirically?
Great. I think it's time to wrap up. I know we went over time, but I want to thank you guys again for this presentation. I think it was a fascinating discussion, and I'm sure that we'll have continued discussions around these efforts, and hoping to provide the feedback that you guys are looking for from the FDA, and collaborate on this, because it does will definitely make our lives a lot easier. Like Jeff mentioned, it's probably something that I deal with on a daily basis, is to adjudicate these, events. So I want to again thank you guys for your time, and thank everybody on the line for joining.
Thank you again for coming in. It was really great.
Yeah, it was a pleasure seeing you again, Tylo, and it's nice meeting you, Amanda and Kerry.
Great. Thank you so much.
Yes. Thank you all.